now. She's just recently moved to the King Fahd Specialist Hospital, and she's the chairperson of genetic metabolic, and we're very lucky to have her. تفضلي دكتورة. She's going to talk today about the role of liver transplant in organic acidemias and urea cycle disorders, challenges, and new horizon. تفضلي.
Thank you very much, Dr. Azan. Good morning, ladies and gentlemen. It gives me a great pleasure to be with you today. I would like to thank the organizing committee, Dr. Shigrani, Dr. Azan, for inviting me. This is the first time for me to be with you here. Now we have to have a shunt from the previous talk to the genetic and back to the tiny thing that we are going to talk. But I promise you that you will find genetic interesting, because you will see from where all those patients are coming to you. Can I have my slide? On the way? Shall I do anything? Yeah. Okay. So I was asked to talk about the role of liver transplant in organic acidemia and urea cycle disorder, challenges, and the new horizon. And I would like to start with the challenges with some of our patients. And actually, this family came with a baby, the first one, the first, square downstairs is the boy who was normal, and then they have this boy who had, at that time he had a metabolic disorder. He had metabolic disorder of, or genetic disorder of pain and sensitivity, and the mother stopped getting pregnancy till we find the result, because she had, dilemma of taking care with this patient. And the time that we discovered that the patient had metabolic disorder, and we know it, she get pregnant, and we tested the pregnancy antenatally, and he was fine. So the baby, the girl was fine. At age of 8 months, she came to the ER with fulminant hepatic failure. And when the diagnosis was done for her from hepatic and from genetic, she had HLH. So this family, actually, they have now 2 autosomal recessive disorder. And this problem, why I have started with this, because of the consanguinity. Now, up to 10% of our cases in our clinic, they have more than one disorder in their family. And one disorder, not in the tribe. No, I mean the father and mother have more than one autosomal recessive disorder. And this always because, of the more and more consanguinity. So we have to have something not only to treat. Yeah, I know that we are going to treat, but what about the prevention? So my learning objective, I would like to understand the pathophysiology, why you are doing transplant for those metabolic patients that we are sending to you, and review the current indication, timing, outcome of the liver transplant, identify the major challenge, metabolic stability, neurodevelopmental outcome, or ethical consideration, and the future zone. Those should be all in 12 minutes. The burden of inborn error of metabolism and organic acidemia and urea cycle. And for those who had we don't see them a lot, organic acidemia and urea cycles, type of metabolic disorder that present early in life. They present with hyperammonemia, recurrent metabolic acidosis, encephalopathy, coma, death if it's not treated. And if it's treated or on the metabolic diet and nutrition and the OS medication that we are giving for hyperammonemia, they have their own prognostic that they will continue to be disabled, optic atrophy, and this diet which will be lifelong. Why I'm insisting on this? Because usually when we discuss with you guys regarding the liver transplant, and we told the parent they will be on for the liver treatment of the liver transplant, the medication for lifelong, the parents said, okay, we are already on lifelong medication. So why you are so afraid to do it? It is better for the family. At least you remove the stress of the hyperammonemia that the baby may get, have his brain burned anytime, or he need to be strict on formula because when they go to the school and anyone give them whatever, another diet that they are not supposed to take, they get like a crisis. This thing that we don't live with that family, but actually they are the people who are insisting for us, okay, send us for transplant. We are ready to undergo everything, all the challenge, if it's have like 10% improvement. And this touched me actually a lot in my career, not like before when we say be more restrictive. The problem that despite medical management, patients remain at high risk of metabolic decompensation, and as I told you, sudden death or optic atrophy, cardiomyopathy. And the rationale that the liver is primary site of the defective enzyme. So can replacing it service just will make for us everything nice or not? One of the challenge. This is unpublished data. I took it from Wiqaya. They are taking the newborn screening for the MOH. So this is from this result last year for MOH and the private sector. Number one of metabolic disorder in the kingdom is, as you can see, congenital hypothyroidism. Number two is VLCAD. Propionic acidemia, and you can see methylmalonic acidemia in there because I think the data was still not clean. So here MMA and here PPA. So this is one of the most common disorder that we are going to talk about because, you see this is the VLCAD is 50, while 50 per year. Propionic acidemia 43, but when you sum with it the methylmalonic and MMA, this is the organic acidemia, it will be 50 something. And I want to show you something else. From the cases per in the kingdom, Bisha was first in 25 cases and from the 5,000 delivery. Riyadh, of course, it has the highest, but Riyadh 45 from 108, so 105. So the percentage that Bisha is the most common. Okay, what is the most common in Bisha? PPA is 10 cases from this 25. So I don't know if you are really getting a lot of patients from there or not. This slide can show us how much we need to concentrate in the planning because some area really they have a lot of patients coming. For those, the incidence of inherited metabolic disorder in the world, 1 in 10,000. Some people 1 in 40,000. In Saudi Arabia, 1 in 1,000. In Bisha, 1 in 500. 1 in 250. So, and you know what is the cause. So this really we need to, it's not only to, are you going to people to take all these patients for transplant? Are you ready for those number or not? So let's see now what is the rationale and why I'm so excited with transplant these days, but I don't know later on or not. So the organic acidemia, the liver is a primary site of propionic acid and methylmalonic acid. And here the problem, this is the pathway. I will not go a lot in it, but if we have a block here because of the inherited metabolic disorder and the genetic problem in some of those genes, you will have a problem accumulating the methylmalonic, methylcitric, and all the problem will be here. So all this is in the liver. So the key concept difference that if we are going to change the liver for the patient simply, the methylmalonic and propionic acidemia is not only from the liver, they come also from another organs, from kidney, intestines. So the liver transplant is not that magic thing to clear everything. But frequent metabolic decompensation required hospitalization. They have failure to thrive despite optimal medical management. If we say that, let's go to medical management, progressive organ dysfunction, especially renal impairment. Impact on metabolic control after the liver transplant led to more than 80 to 90% reduction in plasma level of toxic metabolite and dramatic reduction in the metabolic decompensation. And they can be a little bit more, liberalized in the protein, taking diet, not protein restricted, but not that common. The metabolic burden is lifted, leading to improvement of life of the patient. The urea cycle is here, which is the whole, it's going in the liver. And this is the urea cycle that I'm not going to talk about, but the liver is exclusive site for the complete urea cycle. So we see sometimes that urea cycle liver transplantation, replace the entire defected pathway, effectively curing the hyperammonemia. And the key concept here is different. The metabolic cure, normalized ammonia, and they can be on their diet. So they actually, with the argininosaxonic and others, we say they are better with it. And because they have a neonatal onset with higher stress of mortality and morbidity, they have frequent hyperammonemia, significant neurodevelopmental. We cannot just wait. Those patients, we would like to give them the best at the beginning or as soon as possible. Impact on survival for the urea cycle, dramatic improvement because liver transplant has transformed the natural history of the disease. 5-year patient survival is now more than 90% of both UCD and OA in major centers. This contrasts with the before highly mortality rate in severe form. Also, liver transplant normalized the ammonia level. Patient can, as I told you, can go on diet, their regular diet, and they can discontinue the ammonia scavenger. They can discontinue some of the medication. The metabolic burden is lifting, as I told you. Okay, yeah. Now we're left with 5 minutes and talking about the multi-facing challenging. The timing. You want the baby to be, bigger or older for the liver and the weight. And for us, this is dilemma because the transplant too early on a stable infant versus too late after irreversible neurological damage has occurred. And the risk of early is the immunosuppression, surgical complication, organ allocation, and the very young child. The risk of late, the permanent cognitive function and cerebral palsy, poor quality of life, even with metabolic status. Even if I transplant the patient, he will be improved, but the brain damage, it's irreversible. The neurological and neurodevelopmental outcome, it is better the earlier we did it, but sometimes, the outcome will also be affected by the neurotoxic medication that they are taking after post-transplant that can cause also some, encephalopathies and other problems. What about the other problems, the key challenges like challenge number 3, the kidney complication and methylmalonic acidemia? As I told you, methylmalonic acidemia, inshallah you remember this morning, I told you it's not only from the liver, it's come from liver and from kidney. So many cases when the patient presented to us, they have already liver damage and kidney damage. So most of now the trend I do liver kidney transplant. And the problem with methylmalonic acidemia that it is mitochondrial problem. So in the beginning, there is mitochondrial dysfunction. And the mitochondrial dysfunction here is the one that we and you post-transplant has struggled, with hyperglycemia, lactic acidosis, what is going with the patient post-transplant. It's not only that we remove the liver. He had methylmalonyl methylcitrate that it is circulating in the body. It's making somewhat our job difficult. Now, lactic acidosis and hyperglycemia, if it's always, we see it post-transplant, and now we are thinking to measure the FGF21, which is a very good marker for the liver tissue and the liver dysfunction. And in one labs in Colorado, they are offering this. Long-term morbidity and immunosuppression, that's also one of the challenges because, there is a risk of infection, renal dysfunctions, with especially the medication, hypertension, and malignancy in some rare disease. So the requirement that this is really lifelong, but need multidisciplinary and follow-up from the team. The other challenge also, the ethical and psychosocial consideration. High cost for surgery, lifelong care. Is it the patient metabolically stable, live with potential neurodisability and immunosuppression is a successful outcome? Some of the parents, they say, yes, we want to decrease the life problem. I want my child can go to school and take anything he can eat. Please do it for him. So it is another problem. Another thing in our country, the case that Dr. Razan, she sent me, she asked me to see the patient was having MMA. She's going to transplant, doing the transplant, and then I was asking the mother, what about the next pregnancy? She say, oh, I got pregnant. So she was already pregnant. She say, oh, mashallah, did we test the fetus? She say, no, I delivered already. Okay, how is the baby? She was again affected. So, sorry, this patient was again affected. This is the first one we talk. So the other problem actually that this mother, we are going to transplant the patient, and then the mother already had another baby who is affected. So another time for prevention. This is one of the cases. This is real case. In the clinic, we have this affected and another, 1, 2, 3, 4, 5. And the father, this is the father and mother. The father has a brother who's get married to the first cousin. The other mother had a sister married to first cousin, all of them, first cousin. And all of them have 2, 3 affected. I think talking with them, doing the premarital screening, preconception screening is important, one of the New Horizon future direction. So one of the new horizon that premarital screening or preconception screening, the family who are positive, please let's talk with each other and let's do expanding carrier testing. The new horizon from your side, you know about the axillary partial liver transplant. There is the hepatocyte transplant that sometimes will stabilize the patient with acute metabolic crisis, but not for lifelong. Sometimes it is like a bridge. Gene therapy and gene addition, we can say that like this gene therapy, it is one part of the transplant, of the treatment and the MMA and the PPA and also urea cycle, but it is not yet, you know, that fully we are starting it. There's some problem because of time. I will go through this and we can put it in discussion. But as you can see, regarding the clinical trial for the gene therapy, some of them terminated, some of them withdrawn because of not effectiveness, but some are still in the gene therapy, and those who are transplanted is contraindicated for gene therapy. So somewhat we need to do balancing between them. Management of the post-transplant phenotype, because sometimes, you know, you need to lifelong multidisciplinary neurodevelopmental support, management of the immunosuppression side effect. So my summary that liver transplant is life-saving and life-altering intervention for severe urea cycle and organic acidemia, dramatically improve the survival and metabolic stability. Significant challenges remain, particularly regarding neurodevelopment, timing, and long-term morbidity. The decision of the liver transplant is complex, must be individualized by multidisciplinary team. The future is bright with emerging therapy, gene therapy, hepatocyte therapy, and that may in one day reduce the need for full organ transplant. And by this, I reach the end. Thank you very much.
Thank you very much, Dr. Amal, for a beautiful presentation. Any questions from the audience? تفضل دكتور ستيش.
In molecular concept, we have molecularly both are molecularly affected. One is by So in molecular genetics concept, we have biochemically affected, molecularly affected. Molecularly affected, biochemically normal concept. So in a family, the two affected siblings, molecularly, one might be symptomatic, another might be asymptomatic. So what kind of surveillance do you recommend for these patients, number one? Number two, we know that like in the metabolic conditions, we have 50% of the metabolic activity from the carriers. So when considering the donors, do you recommend we need to exclude the carriers? That's the second question. The third question to Dr. Shagrani, Dr. Rela, he recently played with two different kinds of metabolic disorders. So can you please enlighten more on that part actually?
Dr. Satish, I have to help you. If you ask two questions, the person that you ask the question to always answers the second first and forget the second first and then forget the first question. And now you do three questions. You're making it really difficult. Let's go for any questions of the three you like, okay, and then we see what you remember.
So if I remember well, the first question regarding the metabolic, what we can do, like screening for metabolic, from metabolites for those patients, like for two kids presented with the same problem. So, you know, the genotype, phenotype, sometimes with our metabolic patients. From like MMA, PPA, urea cycles, we find that the genotype, phenotype is limited with in the same family. It's not that variable presentation in the same family. Maybe in others' family, genotype, you know, mute, and they will present with different severity in the same methylmalonic. One tribe, they have worse than other tribes. In real life, what we can do from from metabolites, biochemical, proteomics, or others, we can, from the gene first, from the mutation itself, and then we can go like plasma amino acid, check methylmalonic acidemia, methylmalonyl. Now the FGF21, it is one of the metabolites that they say that we can, you know, measure it to see how the patient is doing, how it's pre and post. No, a lot actually it's available, and when we talk in real life, those cases, they come just for transplant and let's do it and go. Regarding the second question, as I say, I forget it.
Carrier.
Yeah, the carrier. Important, and we were discussing it. Most of our, the consanguinity in our families is reaching in the clinic 90% and 50% in the Saudi Arabia. Most of the donors are the father or mothers, and even if you bring the auntie and aunties and uncles, they may be carrier. We are doing, and maybe Dr. Razan, Dr. Shagrani, correct me, we are doing the carrier, even with 50% haplo insufficiency, but we think that hopefully they will not manifest or not to have anything. And what I think, but because we discuss it, that sometimes even this liver that we are getting, with carrier, it is doing good function for this patient. So far, we cannot exclude this because this is the available thing with us. Regarding the other question, I thought it was for you, but for us, seeing two metabolic disease or two genetic disorder, and now I'm seeing 3 and 4 genetic disorder in the same family. This is increasing, and this is what we put some of the budget on it to awareness and at least testing the family before they get married. Doing PGD, doing prenatal diagnosis. And for us, for all of us, if you find like your patient is having inherited liver disease and the sibling is having different manifestation, our medical student, before our medical studies, we like to collect everything with each other, to blame one thing. So everything is from, maybe this is other manifestation. No, don't blame everything. Maybe actually it is two disease, two separate. Urea cycle defect, MSUD. Yeah, maybe like this. We have phenylketonuria with the glycogen storage disease. Okay.
I may have a question, the last question of this discussion, and that's about timing of transplantation, like you referred to. If you have an MMA patient, what would you prefer, to do an early liver transplant and take the risk that your immunosuppression take on the kidney at some point as well, but you have lowered the MMA level? Or would you wait rather? What is your preference, kidney-wise?
Yeah, thank you for this question. And again, I think it is individualized for each patient, so it's not uniform. How is the patient himself, if he's still like only liver, which we usually do it, liver now for now, and then we will see the kidney whenever it start to have it, and that's what I see the practice is more, because and even if the liver he's that stable or this phenotype that we can postpone a little bit, the family, they are good for us, they are following, they are near each other, near the hospitals, different than those who when they go, they will not come back. So I think it's every case that we need to think of it.
So do you know the kidney survival after early liver transplant? You have data on that? Does it really postpone kidney transplant?
Actually, I don't have data on this, sorry.
Okay. Thank you very much, though. Thank you for your presentation.